Okay, so page 159, troponins, not just for acute coronary syndrome is the title of this section. This is nicely written by Peter Vecellio. The troponin complex, just reminding you, is troponin C, T, and I. C is not helpful because it comes from more than just the heart, but T and I are helpful. You know, it's silly to get into prolonged discussions about our troponin assay versus your troponin assay, our troponin I versus your troponin I, that type of thing, because it's a moving target. You know, there's been dozens and dozens and dozens of different assays by different manufacturers, and really things are converging. The fact of the matter is that these are amazingly sensitive for myocardial injury and necrosis, and they're amazingly specific. They're very, very good tests, both of them, troponin T and troponin I. The differences as we go along are becoming less and less as these assays become more and more refined. And so that's the first thing. Both troponin T and troponin I stay up longer than with the last thing that we were all accustomed to, which is CKMB mass. And so keep that in mind, that it could be several days since the infarction if someone has an elevated troponin, and it may not time the infarction as well as CK did in that respect. So it's still important to be aware of that for either troponin T or I. You know, it depends a little bit on the assay, but probably seven days is probably the median time. And, you know, we had a big discussion recently at our hospital about whether or not we were going to get rid of CKMB altogether, and we've decided to do that because I like to use CKMB when someone had a positive troponin, maybe they had an infarct and a bypass a week and a half ago or something, and then they represented with chest pain that seemed to be incisional pain, that type of thing. I wanted to have a CKMB available to know maybe the troponin is still up, but the CKMB is negative, meaning that it's all old. But I was able to be convinced that because it was a very expensive assay to maintain CKMB at our hospital, it would cost us a lot to make it available, and because you can still follow the troponin trends. So if the troponin is coming down and then it comes back up again, I was able to be convinced to give up the CKMB that was so beloved to me. I love to have that in my armamentarium, but I think it's probably sufficient to just use the troponins now for the reason I just mentioned, because you can still trend it. So it doesn't really so much matter what test you use. One other very important fundamental thing is that I can't compare my my troponin values to your troponin values if we use different assays and if they're calibrated differently. You know, how do we communicate? How do we have a similar language? How do we decide what is the threshold for MI? And the way that we do that is relative. We have adopted the standard of the American College of Cardiology, which is to say that anything past the 99th percentile of troponin, okay, in normals, anything past the 99th percentile, we're going to consider the threshold for MI, okay? And so that's obviously arbitrary, totally arbitrary. And it's necessarily arbitrary. You know that. I mean, you know that at your hospital, if you get a troponin at ours, if 0.1 and 0.2 are mildly elevated, and 0.3 is our threshold for MI, and it says that on the lab form. You probably have a different one, Ed, and everyone has a different one. The point is that these are all based on a standard curve and an arbitrary cutoff point. Okay, we're going to use this as a tool, and we need to have some sort of cutoff point. We're going to get into a little more depth into what elevated troponins mean and whether they mean just acute coronary syndromes or not as we go forward here. One other thing that I think is and there's another little bit about CKMB that I'll mention just before we move on, which is that CKMB is less specific, okay? And so what does that mean? That means that there are other things that can elevate the CKMB that aren't a heart attack, and it's less sensitive as well, meaning there are people that we find have elevated troponins, right, where the CK is negative. So we have people that maybe we think have an acute coronary syndrome that have these grumbling low levels of troponin, and we think that's very significant because that's a prognosticator for them. In some of those same patients, the CKMB doesn't even register. So it's important to understand that troponin is better than CKMB in all respects. It's more sensitive and more specific. The first article there, Abstract 1, is something that comes up a lot, I think, with the nursing staff, and it means a lot to the patients, which is, do I have to stick the patient from a separate needle stick every time to draw a new troponin? The answer, No, you don't. You can take it from the saline lock. And so that's an important paper that you might want to use if your nurses feel that uncomfortable about not resticking the patient for the troponin. You don't have to. Technically speaking, when you have a saline lock and you're supposed to discard the first tube and then you can go ahead and do it, that's an acceptable thing to do. And so you can put in a saline lock and you don't need to restick these patients. That's an important practical thing. The second issue that we'll address is, does an elevated troponin mean myocardial infarction? Is it always that same mechanism? And the abstracts number 2 and abstracts number 3 unfortunately really don't tell us much. They attempt to tell you that we have a lot of patients that have elevated troponins and we take them to the cath lab and a whole bunch of them have completely normal coronaries, or they have non-obstructive coronary disease that we don't think is responsible for the troponin elevation, and therefore it must be something else. And here are the various things that we think are causing the troponin to be elevated. But it's very much conjecture on their part, and they've both taken different interpretations of them. The first paper, abstract 2, has basically said, well, if the angio is negative, it must be something else, and here are the things that it could be. And they list a whole bunch of very, very silly things, including, I believe, tachycardia and some other things that, it's not clear to me how that might cause an elevated troponin. Tachycardia, the mechanism isn't really there. Diabetic ketoacidosis is not clear to me specifically how that might cause an elevation of troponin. And so these things are largely conjecture. And I think the sort of underlying flaw with both of these studies is this concern about using the cath as the gold standard. The cath is not a gold standard. Just like the MRA is not the gold standard, as you heard me ranting about, for subarachnoid hemorrhage. The cath is not the gold standard for acute coronary syndromes. If you have a positive troponin and a normal cath, okay, there are two possibilities. It could be that there's another cause for your elevation of troponin, like myocarditis is one that I know for sure pathologically causes dead heart cells, or it could be that it's a falsely negative cath. This is something that happens. And that's what actually the authors in abstract 3 are trying to get at. These British authors are saying, well, when the angio was negative, it's probably not that it was really negative. It's probably that we delayed the cath too long and the clot disappeared. And they were actually advocating in that study that despite a negative angio, that we should aggressively modify the cardiac risk factors in those patients, and those are the patients that probably really do have acute coronary syndrome. In fact, they're saying we have some good evidence for that, which is really not good evidence at all, which is that they have very elevated high sensitivity C-reactive proteins, et cetera. Oh, so they must have been missed acute coronary syndromes if the cath was negative. I mean, there's a lot of, so those papers in and of themselves don't do much to tell you, they don't really tell you much, but at least they bring up this notion that there are other things that elevate the troponin, which I do believe is true. So we haven't really got that far. Now, let's talk about another common belief, which is acute MI a common occurrence with stroke? And specifically what Peter's referring to here is ischemic stroke. And so it's long been taught that there's an association between acute stroke and acute MI. And this was based on what? This was based on CKMB. Now with this new, more sensitive and more specific measurement, the troponin, we have found that, in fact, none of those people had elevated troponin levels in this study that had elevated CKs. And so therefore, an elevation of the CKMB level after ischemic stroke is not a reliable marker for myocardial damage. The CKMB elevation that you get after a stroke could be from other sources, like, for example, the brain itself, right? Remember there was CKMM and CKBB and CKMB. It's likely that there's a little bit of leak from other sources. So that's a very important thing that troponin has enabled us to know, which is that, you know, these people really aren't having a cardiac event at the same time as their ischemic strokes. It brings up, I think, an important point, though, which is that there is a relationship between heart attacks and strokes. And between myocardial necrosis and strokes, but not so much in ischemic stroke, more in subarachnoid hemorrhage, actually. And you guys have all remember that, so your point, what you're doing in your sky is you're doing the EKG that you sometimes see in a terrible subarachnoid hemorrhage, right? They have those ST depressions, deep T-wave inversions, that type of thing. That really is cardiac, to the best of our understanding. And those patients often do have troponin leaks. And the reason for that most likely is adrenergic hyperstimulation, increased myocardial demand, and subendocardial ischemia. And that, you know, there's quite a bit of work that's been done on that. But that's not the case. It doesn't appear in ischemic stroke. And that is probably just we just were misled by elevated CKMBs that were just really not indicative of heart damage. But with the troponins, they do sometimes go up in the subarachnoid hemorrhage people, and that's real subendocardial ischemia. So that's one thing. The other thing that I should bring up here, which is much more clinically relevant, let's talk about some clinically relevant things, is that any time someone has a positive test in the heart, EKG or troponin, and they've got a stroke, what should we think about? There's two things that we should think about. One of them is the big, huge red tube that connects the two of them, right? Yeah, the aorta, and whether it's dissecting or not. So if someone's having a cardiac event and a neurologic event, you know, two systems along the big red tube, and you can add the kidneys in that as well, and the legs, you know, like the leg is hurting them. Two things along the big red tube, look at the aorta for dissection. So, you know, I would be leaning towards imaging those people. That's the first thing. And the second thing, which is probably a little less important, but the possibility that they had an MI a few days ago, they've got an elevated troponin, and they've got a mural thrombus. And so sometimes you might want to look at the heart with an echo and see if that's the case. So those are probably the two practical things that come out of that paper that I would discuss with you. The next section is about pulmonary embolus. Can troponins be elevated in the face of pulmonary embolus? The answer is yes. And the most likely reason, like Peter is pointing out here, is not that they're having an acute MI. I mean, if a 38-year-old woman comes in who's on the birth control pill, who's smoking, okay, she has a swollen leg, and she comes in and she's acutely short of breath and she's hypoxic, and you diagnose a PE and her troponin goes up. It's not because she's having an acute coronary syndrome, right? Why is it? The bigger the embolus is, it's more likely that she has right heart strain and she has consequent subendocardial ischemia from the right heart strain. So this is probably what's going on. And so that is another cause of elevated troponin that's not from an MI. Okay, so already I'm pretty sure that necrotic heart cells from myocarditis, I'm pretty sure that's a non-acute coronary syndrome cause of elevated troponin. Pulmonary embolus, it's from right heart strain is the other thing. Yeah, and I'll get that in 1 second. And the other thing that I think that Peter said that was quite good here, which is that make sure you take away from this study the fact that chest pain plus shortness of breath and a positive troponin does not necessarily mean ACS. Now, I just want to qualify that one bit, which is that if a woman, like we were talking about, comes in with this history and she has her troponin drawn and it's elevated to like 0.5 or 0.6 or 1, there's a good chance that this is a submassive pulmonary embolus, and you're going to do imaging for that and or whatever you're going to do to determine that at your hospital, usually a CTPA at ours. But if her troponin is 40 or 50, probably is having a heart attack. Yeah, so I just want to make sure that there's elevation and then there's elevation, right? And so these are usually small elevations in the troponin that we're talking about with pulmonary embolus, and they're from the thinner-walled right ventricle. I mean, if you infarcted your whole right ventricle, your troponin couldn't even get that high because it's such a thin amount of muscle to begin with. Yes, sir?
I've heard from our pulmonologist that an elevated troponin, not a massively elevated troponin, an elevated troponin can also be, I don't know if it's prognostic of their future outcome with PE or not. And I don't know if you know that.
So there's no studies in here that directly look at the prognostic value of troponin in pulmonary embolus, but I'm sure that that's true. I'm sure that that will turn out to be true, as it has in other disease processes, the troponin. And we're going to get to this as a theme, that troponin elevation is probably a predictor of badness in general, regardless of whether it's acute coronary syndrome or other entities. So far we've got a couple of things under belt here. We've got the myocarditis, which I think you guys all believe me on. We've got the pulmonary embolus, which we've got one study to support that as well. And the other thing that I should mention, it's not really addressed in this particular group of papers, is dissection can have elevations of troponin. Some of it might be due to subendocardial ischemia from a hypercatechol state in people that were susceptible, but there are some people that really believe strongly that there's a small amount of troponin-bearing cells at the bottom of the root of the aorta. And this is something that Billy talks about a lot, and something that he's very interested in terms of research area is the elevations of troponin. Again, not huge ones that occur with dissection. And so maybe we just step back a little bit with an open mind and recognize, hey, a little bit of elevation of troponin does not an acute coronary syndrome make. There's PE, there's dissection, there's myocarditis, just to list 3 things already. Now the next section, as we further muddy the waters here, has to do with COPD. And this is actually quite interesting stuff. These next 2 papers deal with taking patients. These are chart reviews, and the first one is pretty good in terms of its methodology. They've taken 235 people with initial N. And at any rate, there's a large number of people that come in with COPD exacerbations, especially as you get to the sicker end, that have an elevation of their troponin. And in this abstract number 6, 25% of them had an elevated troponin. But they're looking at those patients and they're saying, but none of these people seem to have anything cardiac. Now, a lot of them don't have a gold standard for saying that, but if you look at the numbers, they're pretty reasonably impressive to most people. Only 10% of those people had any new EKG changes when compared to old, and only 6 of them ended up with the diagnosis of myocardial infarction. So there's a huge number of people that do tend to have troponin elevations in COPD, and a very small number, at least in these papers, which are reasonable papers. They're not RCTs or anything, but they're reasonable papers. They seem to have elevation of the troponin that's not related to acute coronary syndrome. Now, why might that be? Why would a COPD patient in acute exacerbation have an elevated troponin? The same thing like in PE. Yeah, the same thing like in PE, right heart strain, right? Acute, severe right-sided heart strain. Again, subendocardial ischemia probably in the right ventricle. So I think you can add that onto your list of things that we're pretty sure cause elevations of troponin that are not acute coronary syndromes. I don't think all these people are having acute coronary events. So that's number 6 and number 7. And then we get to the ultimate quagmire, and I hope we don't get stuck in this one and never move out, because a lot of people are very interested in this. This is the whole entity of myocardial contusion, which is the mysterious entity that is so elusive of description that we speak of often with our trauma colleagues. The myocardial contusion. What the heck is it? How do we diagnose it, and what does it mean? There are papers on this that mostly come from trauma departments. They mostly come from fairly unsophisticated methodology where they're sort of just enrolling all these people that they're admitting to their trauma service. I'm especially familiar with the first paper, Abstract 8, which was done in my presence by our trauma surgeons, and I'm actually good friends with the head author of that, Ali Salim, who's now one of the, I guess he's the chief of trauma surgery at Cedars-Sinai now. He's moved on from USC. He was the program director for surgery critical care, and he's a wonderful guy. And this was actually one of his earlier studies. And I know all about it because I saw the patients sort of, as they were going through this study, and I kind of have the inside scoop. Let me just tell you that for all 3 of these studies here, the middle one, the abstract 9, is I think it's of little significance because it's like 17 patients and it's just describing what happened to them. It doesn't really prove anything. But abstracts 8 and 10, let's talk about those in a little more detail. The problem and why we're so wary of this whole thing with the myocardial contusion is that they all have incorporation bias. They all have some problem where there are common elements in the way that they define the disease and in the measures of outcome, the way that they define the disease and the measures of outcome from the disease. So, for example, they are describing myocardial contusion. What's a myocardial contusion? And they'll say, well, a myocardial contusion is a person with an increased troponin, for example. And then they'll talk about troponin as one of the, they'll talk about the sensitivity of troponin in diagnosing a myocardial contusion. And then, not only that, but sometimes entry criteria include things like arrhythmia. What is another entry point to call something a myocardial contusion? Well, let's say if they have an arrhythmia, then that might be a myocardial contusion. And then the study will turn around and measure arrhythmias as an outcome measure. So the patient got into the study as having a myocardial contusion because they have some arrhythmia, and then they go around and take a look at the risks of myocardial contusion because it can cause arrhythmias, that kind of thing. I mean, there's a lot of cyclical reasoning in here, both in the way they define it and in the way that those things overlap with the outcome measures. So it's a very messy, cyclical situation. It's a cat chasing its tail that we've gotten into with this whole myocardial. So that's why no one really knows what a myocardial contusion is and what the significance of it is. The fact of the matter here, the bottom line, is that these patients that we enrolled in these studies were patients that we decided to admit to our trauma observation area because they had major trauma, because they had a massive bruise on their chest and they were painful all over their chest. They looked like they had a broken sternum, that type of thing. And that's why we admitted them. We admitted them based on our medical judgment, the same judgment that we had even before the troponin assay existed. And then we measure the troponins in them and make all sorts of conclusions. But at the end of the day, none of the decision-making on these patients was based on their troponin. It was all based on their mechanism of injury and other things that were going on. Now, it so happens, And the only thing I think you can conclude from these studies is that those patients with the elevated, I know it's very just to get your head around this stuff is very confusing. These papers are very confusing because of their cyclic nature. But the only real significance of the troponin is that the people that had elevated troponins do badly. Now, you just hit on that earlier with the concept. That's a theme that runs through every single disease process. People with elevated troponins do worse than their counterparts without elevated troponins. And the same is true for a trauma victim. If their troponin's elevated, they tend to do badly. But we don't need the troponin to help us with that. People that have a car hit them and broke tons of ribs and whose ribs are fractured, who are panting from breath and have pulmonary contusions, I admit those patients. Patients that look fine, okay, and don't have that type of trauma, I don't admit them. And the troponin is really not part of the decision-making process. Yes, it turns out that the people with the elevated troponins do worse, but really it would not affect anything that we do. And I can tell you, it didn't affect anything that we did while these patients were being enrolled. We just happened to start measuring things as they got admitted. So I really think that this is of no value. And I'm still really question why we would measure a troponin on someone for prognostic value when we'd already made up our mind that we were admitting that patient because they were severely traumatized. And that's really the issue here. Okay, so if that's not too confusing, if I've tried to say that as succinctly as I can.
I guess the only question would be is the guy said that he was having chest pain before the accident.
No, beautiful point. I mean, and I should, that's another thing. I mean, yeah, I mean, if this is a single vehicle accident where a guy hit a guardrail, you don't have an explanation. I mean, that just goes, that just speaks to the whole nature of our specialty, which is always to think about the other reason that he might have had the trauma or that she might have had the trauma. So that goes without saying, yeah. And so so you're going to work that up as well, yeah.
What is the gold standard for diagnosing contusion?
Well, there is no gold standard for diagnosing contusion, and the gold standard is going to be the same as our entry criteria for the study, and it's going to be the same as our outcome measures. That's the whole problem here. You have to decide what the goal. Now, if we had a magic test that was a yes or no answer, measure the cardiac contusion enzyme, and it was positive, and then we could. But we don't have anything like that. And I can tell you just as a practical matter how very, very silly this type of stuff is because, what it really means, and they're saying they have significant arrhythmias, if they have a contusion, you've got to watch for it. This is what it means. It means that our head of trauma comes down, does the EKG, okay, on these patients that come in with their chest trauma. The decision's been made to admit this patient, and he goes like this with the EKG thing, and he looks at the top line. It says abnormal EKG. Says, abnormal. That's what he does, and it's like abnormal. This is positive. It's this is a result of the cardiac contusion, and this is what's been going on with this stuff. It's really just silliness. So I do believe that patients hit their chest and injure their heart. I do believe that happens, and I think they do okay with it, generally speaking. I think sometimes maybe they don't do okay, but explain to me how that's going to change what I do for a living. I'm going to take patients that are severely traumatized, and if they have an arrhythmia and they have VTAC, I'm going to take that seriously and I'm going to monitor them. But I don't see where the troponin really comes into that. This is not something that changes decision making for me. Yeah. And then on the other hand, if someone comes in and they're not that badly, they don't have any significant injury to their chest, what are you going to do? Measure their troponin to see if maybe they're, unless they had, a medical condition and they said they had chest pain before, that kind of thing. So really this is something, and the reason why, it's worth making a big deal out of this stuff is this is the same sort of cyclical reasoning that gets us into so much trouble in our traumatized patients. It's the same thing with drug screens. It's the same thing with lipase and amylase measurements. I mean, we measure this stuff and it costs money and it doesn't help us. And so troponin is almost like a poster child in the trauma patients. But you've probably seen other things that your surgeons are asking you to do, right? A person is, has some belly trauma, and you're asked to order an amylase. Just take that as another example. How does that change anything? If they've got major trauma in their belly, you might CT them. You're going to do serial exams. How does the amylase change that? And yet it costs, every time you order these things, it costs, whatever it is, $75, that kind of thing. And so, as you can see, I'm not so enthusiastic about troponin. Now, troponin is, like it is in so many of these other disease processes, like in PE, like in MI, like in acute coronary syndrome, okay, a marker of injury. It's a prognostic marker. It is an indicator of badness. But that doesn't necessarily mean that it should be used as part of our diagnostic algorithm for trauma patients. Now, where are we at? And I tell you, most of these things that were, these complications, these arrhythmias and so-called things that we were watching for in those patients were like the patient had a PVC. or the patient had a brief episode of AFib. Well, do you believe that a patient who's stressed out and who's just been in a horrible car accident and goes to to be observed, do you believe that that patient can have a run of AFib? Does that happen? Does that necessarily mean that they have this entity cardiac contusion? Does that, who knows? Who knows what the significance of all these things are? Now, the next thing is are troponins, this is on page 163, are troponins elevated in pericarditis? Okay? I love this. Because what is pericarditis? What is itis? Inflammation, right? Peri is around. The pericardium does not have troponin, okay? It's just the surrounding tissues of the heart. When the troponin is elevated, guess what? It's not pericarditis anymore. So for me, this is just a matter of definition. And when the troponin is elevated in what you thought was pericarditis, what two things should you be thinking? I mean, let's just keep this practical. Yeah, they're having a heart attack and you missed it, right? They got ST segment elevations. So your first thought should always be STEMI, 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 STEMI. It would be, who here would take a patient comes in with, you think it's pericarditis? Okay, I can understand that. There's PR depression and all the funny things that make it more specific. It's in every lead. Who here, when the troponin comes back at 1, is going to say, you know what, it's just a little bit of myocarditis with it, and then who's going to do that? We're not going to send that patient home, right? So the two things it could be is a STEMI, or it could be that it's not pericarditis, that it's myopericarditis, which is a different disease than pericarditis. And those people should be admitted. Who here is going to send home the patient with the positive troponin? Right? You're not. So look, there's nothing practical for you to know other than you've got someone who you think has, you've got an increased trope and someone you thought has pericarditis. Here's how you deal with it. You do a cards consult. Okay? That's how you deal with it. You get another troponin. Yeah, you may give them an aspirin. It depends on what else is going on. You guys are done? Okay. The next one, we're just coming down the home stretch here, is the elevation of troponin in end-stage renal disease. Okay, and this is a real hot topic because, and why is this important? Again, let's just keep this down to the practical things that you want to know before you get out of here, which is that, why is this an issue? This is an issue because you have a patient with renal disease that's on dialysis or that's end-stage renal disease, and you've measured a troponin because you're concerned about acute coronary syndrome, right? And someone else is blowing you off. Is that not why we're concerned? That is the issue here, okay? And so what you need to remind them, and Peter writes it very nicely here, okay? What you need to remind them is, excuse me, last time I recall, the most common cause of death in patients with end-stage renal disease was acute coronary syndrome and myocardial infarction. That's how they die. That's number one, okay? Number two, you can tell them that regardless of whether or not this elevation of troponin is due to an acute coronary syndrome, you can tell them that the preponderance of evidence, including one article here that was in the New England Journal that they didn't include here, shows that it's an excellent marker of mortality nonetheless. And so if you've got renal failure, renal disease, end-stage renal disease, okay, and you've got chest pain, or shortness of breath or something that you think is an acute coronary syndrome, and you've got an elevated troponin, I don't care whether they're going to necessarily end up having a positive cath and having a stent or a CABG or whatever. The issue is that they have a high mortality, and they should go to the unit, and that person who's trying to blow you off on the phone should get their butt in. That's the bottom line here. Okay? So it's not necessarily that it means that they have acute coronary syndrome, but it is an incredibly convincing marker of mortality, nonetheless. Okay? So that's the bottom line here. And the New England Journal paper, these ones say the same thing, 12 and 13, but the New England Journal paper that I'm talking about specifically broke them down into 4 strata, where it was no elevation of troponin, mild. And by the way, when I'm talking about the types of elevation, I'm talking about in the sub-MI range here, like, the 0.15, the 0.2, the 0.3. Are these kind of similar numbers to what you're getting in that range? What's the threshold for MI at your place? 0.7, 0.2, 0.1, what? 0.5. Okay, so we're somewhere in that range. So I'm talking about the ones in that range, and those are the ones that the internists are blowing us off on, right? You need to explain this to them, and then pull these paper out and roll them up and use them. Right? You can smack people with them. So the second strata, was a little bit of an elevation, and the third strata was more, and the fourth strata was in the actual peri-MI range, as I recall. And I wouldn't quote myself on the numbers, but basically the mortality goes, from something small, like a few percent, up into like really high mortality, like 40%, something like that. I mean, it really, really makes a difference. So troponin is important as a marker of disease severity in general and mortality, and that's what they need to be reminded of. So again, it's acute coronary syndrome until proven otherwise, as far as I'm concerned. When the troponin is up, they're sick, and they need to be attended to. They should not be blown off. And God, the number of times, and I hear it over and over again from my internal medicine residents that I interact with and fellows, this just constant knee-jerk to blow off the troponins in these patients with kidney disease. It's not the right thing to do. The last paper here, I'm going to leave you with something that's a little bit sort of on the fringe here, which is the Takotsubo syndrome, otherwise known as the broken heart syndrome, right? And so what a beautiful way to end our time together as we get teary-eyed and emotional. It's just an interesting little thing here. I know that there's a lot of people who think this is complete crap, okay, but I'll just tell you what it is, and it's kind of interesting. This Japanese word takotsubo refers to the octopus net that they use, and I guess it's the shape of the octopus net, where it's very constricted at the top, and it bulges out at the bottom. I guess this is how you catch I don't know. This is how you catch an octopus. I wouldn't know. It's not kosher, right? Okay, so, all right. But the thing is that these are patients. These are usually younger women, okay, that you would never think had acute coronary syndrome, that you would never think have coronary disease, that something emotional happens to. They're visiting a dying relative, a horrible relationship breakup, that type of thing, who come in with what looks like an MI, and their EKGs look like an anterior wall MI, and you're going, this couldn't possibly be, okay? And their troponins are usually negative, but they may be elevated. But they're not elevated like 50, 100, like your bad AMIs. They're elevated like in the small elevation range. And then when they do the echo, so the story goes on these patients. I haven't personally seen one. Billy was convinced that he saw one a few months ago. The echo has this characteristic appearance that differentiates it from, say, an AMI, where the base of the heart stays very constricted, like this octopus net, and the apex of the heart bulges out, like this octopus net. Like apparently it's something that, oh wow, it's broken heart syndrome. I don't know. But I just wanted to tell, the reason that, so the article's in there it's a bit lighthearted, but a lot of people think this entity exists. I know there's a whole team of researchers at Johns Hopkins that are devoting their career to it, for example. The Mayo Clinic is big on it. You may see this. I know a lot of people are very skeptical, but I'd like to keep an open mind about it. But just one thing, their troponin, just remember, doesn't go up to the high range. And if it does, it's not a broken heart, it's an infarcting heart. Yeah, and so so that's that thing. So if you see any of these Takotsubo things, tell people about it, let us know. Maybe it is an unrecognized entity. And of course their prognosis, they get better from it. They bump a little troponin, or they have no troponin change. This ballooning thing goes away, and then they get better. Who knows? But it's kind of a fun thing to end with.